So thanks a lot for having me. I'm also going to present on some form of gene-environment interaction. And basically, the general idea of what the research agenda that we're trying to do is to try to uh, try to use genetic variations as a measure of heterogeneity and differences across people that could be useful for other form of economic intuitions, economic parameters, or economic differences. So I think that one of the things that can be done very generally using genetic data is really to use this variation, this baseline variation that is set at conception and doesn't change over a lifetime, to try to understand differences across people. And the empirical question is whether this difference is actually, substantial and we can use it or not. But I think there is potentially in this general idea. And in this particular paper, what we do is that we try to see whether there's a differential reaction to a negative health shock, so a cardiovascular health shock, uh, depending on whether you have health insurance or not. And we talk about that as moral hazard. So basically the fact that you change your behavior in response to a health shock, depending on whether you do have health insurance or you don't have health insurance. So this change in behavior, we call it moral hazard. And differences in moral hazard, we try to see whether genetics and genetic variations can be predictive of these differences. So how do we do that? We look at smoking as the main outcome, and smoking as after you suffer a cardiovascular health shock. And we used the health environment study, and in order to use quasi-exogenous variation in exposure to or access to healthcare, we use the fact that after the age of 65 in the US, you get access to Medicare. And so you kind of get access to health insurance. And we compare those who have a high or a low genetic predisposition and see whether they respond differentially after suffering a health shock. And I like to think about this as kind of an interplay between financial constraints, so whether you do have health insurance or not, and other type of constraints that are usually not part of our economic models. So we usually say maximize utility subject to the budget constraint and the time constraint, but there are other constraints that that are different between us, and that now can be measured, such as this genetic predispositions. And I think that in theory, that's a way that we could include it in our model. So the general idea is that the identification assumption is that the probability of suffering a health shock might increase with age. So the older you are, the more likely it is that you have a cardiovascular health shock. But if there's no jump in this probability of suffering a health shock at the age of 65, we see that there's a jump in the access to Medicare, and so we can interpret the differences between before and after 65 as the differences with access to healthcare. And what we find is that those who suffer a health shock when they're uninsured, so before the age of 65, they smoke less. But this is only true for those who have a low PGI for smoking. So those who are not don't have a high genetic predisposition for smoking are the ones who are more elastic in their response to this type of shock, at least in the data that we find. The GYE effect size that we have is quite substantial. Is overall like almost 28 percentage points, so it's quite big. And you'll see more about this. So what about previous work? There's some work that shows that talks about the main question that we're talking about. So the fact about smoking and healthcare costs. So I'm using smoking as the main outcome because, and also thanks to Lauren that presented just before, we can see that smoking is something that can have substantial consequences in terms of mortality, but also in terms of healthcare cost, other type of diseases. And there's a big literature that shows that suffering a health shock actually has an influence on smoking. So the general idea, the anecdotal evidence is that basically if you have a cardiovascular health shock, you have a stroke, you have a heart attack, you go to the hospital and the doctor says, well, you're a smoker, you have to stop smoking because this is very dangerous for you. And we do find evidence that indeed after suffering from various type of health shocks, people reduce smoking substantially. So it's that kind of like wake up call that changes smoking behavior. And there are other studies that show that having or not health insurance does play a role in this change in smoking behavior. So there is evidence of average moral hazard on this type of behaviors. So what we include is this idea of gene-environment interaction, and I think that we try to contribute to this burgeoning literature on gene-environment interaction that you've seen. Many people in the room have substantially contributed to this, and I hope also we're trying to contribute to this idea of trying to include genetic variants into models that speak about deep economic parameters or economic concepts, such as, for example, moral hazard. And again, there's a lot of people in this room have contributed to this idea of trying to think more about how we can include genetic variants into theoretical models of theoretical economic models. So what data do we use? We use the HRS. You've seen it before. It's a representative sample of individuals aged 50 or older. We ended up having some sample restrictions. So we focus on people who were avid smokers, because the main outcome that we want to see is whether they stop smoking. So we focus on the people who smoked at least 100 cigarettes over the lifetime. And we have a window of about 5 years around the 65 age, age 65. So we only focus on people who are age 60 to 70. And since we want to put individual level fixed effects, we only include people that are observed at least for 2 weeks. As it has been said before, we only focus on people with European descent, which could be one of the problems in the literature, but that's what we do by following the general baseline. And overall, what we end up having is about 26,000 observations for almost 6,000 individuals. So what are the main variables that we look at? The main outcome variable is whether you're smoking or not. So a self-reported smoking status 0, 0, 1. We construct an index of a PGI index, and we didn't have quartiles like Hannes suggested. We had only tertiles, and we saw that the second and the third tertile basically had gave the same effect. So for simplicity, we just have a dummy for whether you have a high or a low PGI, or high and low genetic disposition. We use the weights from the G-scan summary statistics. As a measure of health shock, we focus on the first diagnosis. So the first time that you reported being diagnosed with an acute cardiovascular condition. So a heart attack, coronary heart disease, angina, congestive heart failure, or a stroke. So one of those big things that even if you are uninsured, most likely is going to take you to the hospital, going to take you to the emergency room. And this is the main idea. We focus on people who are uninsured, but if they suffer a health shock, the vast majority of these people would go to the ER anyway. What about the people who are uninsured? So we focus on people who are uninsured before the age of 65 and got insurance through Medicaid. Medicare. So we use self-reported coverage that is reported in the HRS. So in every wave, they ask whether they were covered by health insurance in many different types. So through your employer or through Medicaid or any other thing. And we report as uninsured to those who are never covered in the ages 60 to 65 by any type of medical insurance. As I was saying, the general idea is that we do see an increasing trend in the probability of suffering a health shock. So on the x-axis, we have age at the interview here. And here we have the percentage of respondents who report having one of these health shocks, the heart attack or stroke that we mentioned. And we do see that it's kind of increasing over time, but we don't see a jump in the probability of suffering a health shock after the age of 65. These are kind of some summary statistics. We divide them up by low and high polygenic score. We do see that the polygenic score is predictive of smoking. So if you have a high polygenic score, you're more likely to smoke than not. And there is a bit of correlation with being persistently uninsured. So if you were uninsured, those with a high PGI tend to be slightly more likely to be uninsured. These are fixed characteristics. So we define you as being persistently uninsured if you reported never being covered by health insurance. And we control for many of these things by having individual level fixed effect. So that's why we try to soak up that type of variation. one important thing is that in our data, we do find in HRS, we do find that as participant age, they start smoking a lot less. And this is split by those who have a low polygenic index for smoking or a high polygenic index. We do find that there's a difference in level and there's a bit of difference in slopes. Overall, both of them decrease their rate of smoking, but we do find, as expected in some sense, that the PGI is indeed predictive of smoking, and but overall, well, everyone reduces their smoking rates, which is, I think, useful to interpret some of the coefficients that we're going to find. So what is the type of regression that we do? We follow literature in this regard, and basically what we want to see is we want to see whether if you suffer a health shock before or after the age of 65, you respond differentially. So what we have is that we have the outcome variable is whether the outcome variable is whether you're a smoker or not, and then we have a fully interacted model between suffering a health shock, being after the age of 65, being uninsured, and your index of having a high genetic predisposition. And we have a fully interacted model of all of these things, and then we control for a polynomial age, an individual fixed effect, and weight fixed effects.
Clarification question. So in practice, you're doing a double difference, right? You're using the fact that some people were insured before and keep being insured after 65, whereas other people were not insured. And am I right?
Yeah, indeed, exactly. So I'm doing kind of a double difference. Yep, indeed. And basically, we estimate this regressions, and then we use the coefficients to try to see a combination of these coefficients to try to see what is the effects that we care about. This is the combination that we look at, but I think this is kind of the graph that tells the story. So the idea is that those who have a high index of predisposition for smoking, those who have a high PGI, we see that after suffering a health shock, they reduce their probability of smoking. So these coefficients are negative, both whether they suffered a health shock before the age of 65, the red coefficient, or after the age of 65, the blue coefficient. So basically, it doesn't seem that their response to the health shock changes a lot before or after the age of 65. On the other side, those who are with a low genetic predisposition, their behavior responds very much differentially, depending on whether they were covered by health insurance, so after the age of 65, or whether they were not covered by health insurance. If they're not covered by health insurance before the age of 65, what they do is that they reduce smoking massively. The idea would be you have a heart attack, you go to the hospital, you have to pay out of pocket a huge amount of money. The doctor tells you, if you don't want to do this anymore, please stop smoking. And they do reduce smoking quite a lot. On the other side, we find, if anything, a positive coefficient for those who are covered by health insurance. Now, one caveat is that the magnitude of this coefficient is the same as this coefficient. And as you can see, like the precision is not very big. It's a bit imprecise. Yeah.
Well, just to understand what you're doing, the red bar to the left here, this one, is it the people who are less than 65 or the people who are less than 65 and were not insured before the age of 65?
The only people that I showed here are those who are uninsured. So everyone was uninsured. And these are the people who suffer a heart attack before the age of 65.
So all this is conditional on being uninsured before the age of 65.
So this is picking the coefficients that have the interaction with being uninsured before the age of 65.
Okay, thank you.
So this is the derivation, and it's basically the sum of these coefficients give me those things. So basically, the bottom line that we find from this graph is the idea that behavior doesn't change much before or after the age of 65 for those who have a high genetic predisposition, but those who have a low genetic predisposition are much more elastic in their response. They respond a lot more than the others.
Yeah, just to clarify, so the positive blue is like if you get a harder health event, the health shock after, you increase your probability of smoke.
If I could take down to zero, I wouldn't. No, let's put it differently. That coefficient is remarkably robust to a lot of the controls and other things that we do. An interpretation of that coefficient is that everyone is reducing their smoking rates.
Yeah. So if you reduce mortality,
no, I don't. It's not because we have some controls for mortality afterwards. So everyone is reducing their smoking rate. So if you reduce your smoking less than everyone else, that coefficient would be positive. So that coefficient being positive is consistent with the idea that you're reducing smoking, that group is reducing smoking less than the other people. But it is annoying and it's something that I would not want, but the data doesn't agree with me.
But I mean, so if they increase their smoking, like, that would be weird, but if they're just reducing less, that makes sense. But
I think that makes sense. I don't have
Yeah.
a
but I guess you have
clean
to,
way
I
of.
can't figure out.
Yeah, why
I
not?
can't figure out how you're, sorry, with which coefficients are there, so, I mean, I don't know, reducing less
Yeah.
seems fine.
So I think that,
Starting smoking.
yeah. So since we have an individual level fixed effect, we have changes in smoking behavior as the outcome variable, and we're controlling for age, for polynomials in age. So basically, the omitted category is the people who, it is the average person in the sample, which is the majority of the people. Those who are uninsured, who don't necessarily suffer from a cardiovascular health shock, those people reduce their smoking a lot. So positive coefficient is consistent with this particular group reducing smoking less than the rest of the population. I don't have a clean way of proving that only for these people, but I don't. Yeah. I'm gonna stop.
Just to clarify how you define, so it's the group that does get a health shock after 65, right? So
They're insured.
don't get a health shock after 65.
They're
So
insured,
this is
so
a
they're
combination
less likely to take the smoking strategy, right?
And basically, the baseline
fact
is
that you have
the
a
average
health
smoking rate
shock should
in the
reduce the
sample,
probability of smoking no matter what.
after the age of 65.
Yeah, so this can't be included because these people do get a
But
health
it's not
shock unless they
terrible,
don't reduce their
I mean, you could
smoking
They don't reduce their
as
smoking
much
as much as
the
the rest.
rest. But then I wonder,
You would have been
how
surprised
do
if you
you
went the other way.
define a post 65 health shock? Because I could imagine that the reduction in my smoking rate after 65, it's sort of an average. Let's say I get the
Yeah.
health shock at like 68 or something. So maybe at first I don't reduce my smoking a lot because I am insured and because
Yeah.
overall has a problem. And then it's sort of an average. So maybe after the shock, they do reduce.
So all of this is contemporaneous in the sense that I ask you in the same wave whether you're smoking now, whether you had a health shock in the past 2 years. It's a 2-year wave, so I know if you had a health shock in the past 2 waves, and I know your age at that particular wave.
So then the smoking is measured after the post 65 health shock.
So I define the health shock as being post 65 if
Yeah.
the health shock happens in the yes.
Yeah.
So for example, there's people who are 66 and they tell me that they had a health shock in the past 2 years. I don't know if they were 64 or 65 when the health shock happened. So what I can do is that I can do a donut and drop those people or include those people. The results don't change if I do that.
Yeah.
Yeah, but the smoking it's measured then at age 66.
At age 67, let's make it
Yeah.
so for simplicity, age 67, I know whether you're smoking or not. I know
Yeah.
whether you had a heart attack in the past 2
And they're
years.
always asking like, are you smoking now? Yes or no? Not,
Yes.
Are you smoking? Yeah. Okay.
So this is the main results basically. We do find that using the PGI, the index of low PGI as a measure of differences across people, we identify some people who are more responsive to the health shock than others. So we interpret this as an evidence of heterogeneity in moral hazard. So people who are covered or not covered, my response to the health shock changes depending on whether I have or don't have health insurance. So I call that moral hazard, and I call this heterogeneity in moral hazard because these people display moral hazard, these people don't display moral hazard. This is if you buy our story, but I didn't buy my story. These are just the coefficients that you see here, and I think that basically the main thing that I want to show you is that this main result is kind of robust to many of the things that we can think of. As I was saying before, initially we had Churchill's, but we did see that the middle and the high PGI kind of behaved in a similar way, so we grouped them together for simplicity. Another thing that we can think of is that something else might happen at 65 that is actually driving the change. So if we plot the share of people who are covered by Medicare, we find that there's a huge jump at the age of 65, regardless of whether you have a high or low PGI. Here, another thing that happens is retirement. So we do see that there's an overall increase in people who are retired. There's a bit of a jump, but it doesn't seem that this jump is driving our results. So what we can do, and I think I show it here, we can use retirement as an outcome variable, and we can use retirement as an outcome variable instead of smoking, and it doesn't seem that retirement differential response. So it does not seem that the results are driven by retirement or by income. So we don't see retirement going up and income going down, but they don't seem to be driving the results. The big difference is that we find in these people at 65 is that they are covered by Medicare.
Oh, excuse me, one other thing. When you say not insured, do you mean not insured by Medicare, or
Not
do you mean
insured by
not insured at all? Okay, fine.
At all.
You have this information.
Yes, we have this information. So they ask detailed questions of what type of health insurance you have. And if they don't report any type of health insurance, we define them as persistently uninsured.
But the graph that you showed was only about Medicare, not about any kind of
This
information.
is only for Medicare. You're right. Yes.
The responsibility is much smaller for any insurance, right?
Mhm. Yeah, so the sample size is much smaller for
Yeah.
uninsured, but I should show that. I should create that one.
So how many people were uninsured in the data?
I don't have that information top of that. So, and let me check here. So the share of uninsured is where is it? Is small. It's less than 10%, if I remember correctly. So persistently uninsured is about 5.4% in the low PGI group and 6% in the high PGI group.
So your effective sample size in the sense is 300-400 because the
The
insured,
effective sample size is a lot smaller.
yeah, because
indeed.
the insured people, they're not doing anything to your specification except for adding some stuff.
Exactly. They're estimating some of these coefficients. I use all of the sample because I want to use as much information as possible to estimate any of these coefficients. And then I do a fully interactive model precisely in order to be able to get the some sample that I care about. But I want to use as much information as possible to estimate all of the coefficients. But I could do the same thing just focusing on the persistently uninsured who suffer a health shock and do the analysis without. Yeah. And that's why we have such big standard errors, right? We're not very precise in our estimates because the effective sample size that is hit by shock is and we don't try to hide it. We try to be as honest as possible. This didn't help, but anyway. All right. So one thing is that there could be potential confounders. So there could be other things that are driving this. I think that interesting thing is, for example, look at out-of-pocket medical expenditure. So what we see is that if you suffer a health shock before the age of 65, you spend a lot more money. And that's consistent with what we would expect. If you are covered by health insurance, it doesn't seem like your health out-of-pocket medical expenditure changes much. The interesting thing is that the out-of-pocket medical expenditure is kind of similar between low and high PGI individuals. So it doesn't seem that they're shocked by different type of health shocks. They seem kind of comparable. And these levels are different, but the differences between these two are kind of the same. So I don't find the gene-environment interaction in out-of-pocket medical expenditure. I only find it on the behavior, on the smoking behavior. The other thing that we did, we had other type of potential confounders. We tried to do the same. For example, mortality. It doesn't seem that mortality 2 years after the health shock is driving our result. It doesn't seem to have a gene-environment interaction in that thing. So we follow Hannes' paper on trying to put the potential confounder on the left-hand side and trying to see whether that could be a problem. The other thing that we do is that we try to use different cutoffs for the PGI, and we find kind of similar results. We use another much older GWAS and construct a PGI according to that one. Again, we find very similar results. If we change the definition of being uninsured, so for example, you are insured only 1 out of 3 times in the 60 to 65 period, we actually find slightly different results in the sense that the people who were, the results kind of go down. If we look at people, who had some insurance before, not the persistently uninsured, for them there's less change at 65, and we do find fewer differences here. The final thing that we did is, I think, similar to what was suggested before. Is it really genes? Do we need to use these PGIs in order to understand heterogeneity in moral hazard, or can we use other measures? So the other thing that we thought about was, for example, cognitive skills or conscientiousness. Why do we use conscientiousness, for example? Because you go to the doctor and the doctor tells you stop smoking. Conscientious people might be more likely to follow the doctor's advice, or gender, or education. Those do not seem to be driving the results. So if we split the sample according to tertiles of conscientiousness, for example, we don't find these systematic patterns of differential response in the behavior. One thing that I think is interesting is that we can use other PGIs. We use the PGI for smoking because the outcome variable is smoking. So our idea is we should look at that first. But then we try to use the cognition or the risk aversion PGI, and we find similar results, but in the opposite sense. So those who have a high PGI for cognition are the ones who seem to be displaying moral hazard. And those who have low risk tolerance, low risk seeking, are the ones who seem to be displaying the moral hazard. So overall, it seems that in this particular case, using the PGIs seems to be better at identifying those characteristics that might be driving heterogeneity in moral hazard. And sorry, I got lost. So to conclude, there are some limitations of the study, of course. So the first limitation is that we have a small sample size, especially because we're looking at people who are hit by a health shock, because the literature has shown that those who are hit by health shock are the ones who respond the most. So in some sense, replication would be very, very helpful. We're not aware of a data set that can help us doing the replication of this, because we need a data set in the US where we have information on smoking, health insurance status, and having a health shock. So we haven't found one data set yet. And we only can look at the short run smoking response, right? Because I have this panel dimension and include individual fixed effect. I can only know whether you're smoking now and you have suffered a health shock in the previous, between now and the previous wave. I cannot do the same thing in the long run smoking behavior because of the identification strategy. So that's only like, I only know whether you reduce your smoking right after the inhalation. And then in terms of external validity, this idea of Medicare, of course, it's a very thing that is specific to the US health insurance system. And the type of people who are uninsured, persistently uninsured, are not a representative sample of the whole population. So it is, in terms of external validity, it is something that might not, we might not find the same thing in the Dutch data set, for example. So overall, the take-home message is that we do find that if you suffer a health shock when you're uninsured, you stop smoking, and you stop smoking a lot less than when you're insured, only if you have a low polygenic score, a low index of genetic predisposition. And this seems to suggest that there is some form of interaction or interplay between the financial constraints of having to pay out of pocket a lot of money and your biological constraint, how easy it is for me to stop smoking. If I have a high PGI, likely it's harder for me to stop smoking, and I am less reactive, less elastic to the external constraints and external shocks. And we think that this could be a model of a biological foundation for potential heterogeneity in moral hazard. Thank you.
Thank you. Okay. Thank you to the organizers and to Pietro for inviting me to discuss this very interesting paper. Even though I am very much an outsider, everything I know about genetics, I learned in the 2 weeks before the AP biology exam, and I forgot the band. Nonetheless, this was very interesting to me, in part because I don't know anything about genetics, but I have been working on both health insurance and smoking and addiction for a while. I read this paper as making 2 important points. The first is a general point that genetic variation is an observable and useful source of heterogeneity in insurance preferences broadly defined. So on the moral hazard side, but probably more broadly than that. And then to substantiate that point, this paper is a case study of how genes moderate the impact of health insurance on health behavior. Okay, the evidence here is that Pietro shows health shocks reduce smoking. Smoking falls by something like 7 percentage points following a cardiovascular health event. Insurance attenuates that impact. It reduces the impact of health shocks on smoking, but not for everyone. Only for previously uninsured people who gain insurance who do not have a high genetic predisposition to smoking. And it's this last point that really is the reason we conclude that genes moderate the health insurance to behavior. Okay, I have 3 comments in my slides. I'm not sure that I'll be able to get through all of them. I want to start with maybe the biggest picture comment, which is, this is a paper about heterogeneity. So I think it's important to explain why we care about measuring heterogeneity here. And actually, this is, for me, what I take away a big question at this conference in general, and I think the paper helps answer this question, which is, genes are a source of inequality at birth, not the only source, but certainly one of them, that just by chance we end up with different genes and that affects our life outcomes. And we might want social institutions to insure against that source of inequality or that kind of risk. In practice, social institutions or environment might amplify the risk of genes or the inequality created by genes, or they might attenuate. It seems to me that like a prime suspect for the institutions that kind of insure against genetic risk at birth is social insurance in general and health insurance in particular. And so I think, this area in general and Pietro's paper in particular might help us understand whether health insurance sort of amplifies genetic risks at birth. My reading of Pietro's paper, although the presentation did not emphasize this, is that Medicare amplifies genetic inequality. I don't want to misstate your interpretation of the evidence. That's how I read your paper. The case for amplification is that if you are already at high risk of smoking, Medicare doesn't help you quit, or whereas maybe I have this backwards.
Yeah.
Do I have it backwards? Yeah. So good. It attenuates. So health insurance, if you are at high risk, no, I don't know. You want to tell me your
The point is that basically health insurance, Medicaid doesn't seem to change anything for a high PGI individual.
Yes.
If we want to protect people who happen to draw to get the unlucky draw in the genetic lottery, then Medicare doesn't seem to be have an influence on them.
Yes.
Now, the outcome here is a negative outcome. So we just see that the low PGI people are more sneaky, quote unquote, and Medicare helps them do that. So I don't know, the welfare implications are.
Thank you. Yeah, so what I want to point out is just that the moral hazard is, that strikes me as not the biggest part of this story.
Okay.
That what matters also is how insured against healthcare spending you are. And Medicare, of course, provides insurance there. If you're a smoker or have a high PGS, then it seems to me that health insurance would probably benefits you, even if the moral hazard may go the other direction. So I think sort of thinking about the moral hazard in combination with the overall insurance benefit would be helpful. Me though, the motivation here is sort of from genetic risk to social insurance, but I think that there's a complementary question that Pietro's work may speak to, and that I think I would be very interested to see more work on, which is, in general, we'd like to know how effectively social insurance, in fact, insures against the accident of birth. I see that as a kind of fundamental question in both public and health economics, and also hard to answer because, by the time people are making their insurance choices, they're insured, they've made many, many decisions, not all of which were determined by their genes or by the accident of birth. And so we don't know sort of how much of the risk they face is actually determined at birth. The genetic information that I now see is increasingly available to economists seems to open up a lot of scope for estimation for answering or starting to answer these kinds of questions. So let me sort of briefly run through this in a little bit more detail. What we would like to do often, I think, is calculate the welfare value of insurance markets from behind the veil of ignorance, before anyone knew their endowments at birth or their genetic makeup. That's hard to do because by the time people make their insurance choices, they already know a lot about themselves. They're not just insuring against kind of luck at birth. As people get more and more information about themselves, insurance markets typically unravel. because people who know that they're not a high risk have lower demand for insurance. So that's a well understood problem, Nobel Prizes for it. We know also how to solve it, which is we use mandates and subsidies to get more full insurance. But what we don't, I think, have a great handle on is measuring the welfare value of increasing insurance coverage. So starting from a market equilibrium where people know their private information about their type, we can measure using sort of standard revealed preference, what's the value of increasing insurance coverage. Surprising result from the literature, I think, is that there's not a lot of increased welfare from eliminating adverse selection in health insurance markets. The standard, well, there's multiple reasons why that might be true, but one reason is that the uninsured who gain when we eliminate adverse selection don't have a very high willingness to pay for insurance because like they know that they're healthy, they don't need it very much. But before anyone is born, before anyone learns their type, like we might well want to have insurance against sort of being a high risk type. And it seems to me both that universal health insurance provides that kind of protection. And in fact, that's like a prime motivation for social insurance in general, that what we would really like to do is not get healthy uninsured people covered, but reduce healthcare spending or insurance premiums among unhealthy people and people with predisposition to genetic illness. So finally, it seems possible, at least in principle, to use genetic information to start learning about this kind of welfare gain. In other words, you could do something like calculate GWAS for healthcare spending or for the biggest health risks, and then maybe assuming something about risk aversion, try and measure the welfare gain from insuring against the pure genetic risk. Okay, so this is one example of sort of me thinking about why we would care about heterogeneity here, in genetic heterogeneity in particular. I think, in fact, there are many exciting applications for sort of social insurance and health insurance people. That sort of motivation felt a little underdeveloped to me in the paper, and so maybe more on that as the specific. Okay, comment 2 is, should we call this moral hazard? Or more precisely, actually, what I mean is, it's not clear to me why we need this health shock at all. So when I think about moral hazard, I think insurance changes your ability to smoke. Totally plausible that genetics could moderate that relationship in the sense that there might be a different effect of insurance on smoking for people with a high or low predisposition. And it seems reasonable that genes influence who's on the margin of smoking, and therefore we'd expect a different effect of insurance for people with a high or low predisposition. So, starting from this perspective, the research question that I expected was, what's the effect of Medicare on smoking for people with a high versus low genetic predisposition? But that's not what Pietro gave us. What we got was, what's the effect of Medicare on smoking after a health shock for people with a high versus low genetic predisposition? And so, there's a couple of questions that I'd like clarity on. One is, this is a really complicated thing. I would call it quadruple difference because we have pre-post 65, uninsured or not, pre-post health shock or not, and high-low PTS or not. It would be nice to simplify it if we can. If it has to be the specification, though, I'd like you to sort of walk me through why it needs to be this, and maybe why we should call it moral hazard. Because after you have the health shock, it's not clear to me that you have a further incentive to stop smoking. Is it even more costly to smoke after the first heart attack? And then one more comment, which I found the discussion during your talk helpful on, is I think you could say more about the dynamics here. So the conventional wisdom around smoking, I think, is that you initiate in adolescence and then try and quit throughout your life. That's an uncontroversial statement, I hope, but I will use my discussant privilege to cite my own paper here. So we show cigarette taxes in adolescence matter even for middle-aged smoking and mortality. One evidence on this point, there's lots and lots. The timing here is that first you're uninsured and then you're insured later. And so the naive reading of your paper is that people stop smoking at 64 when they're uninsured and then resume at 66. I don't think that's what's going on. And as we sort of suggested, differential sort of quit efforts and relapse rates could explain it. But I think some discussion at this point, or even drilling into there are measures of did you try to quit smoking rather than just current smoking would be helpful for. Okay, so it's an interesting paper that to me opens up an important area. There's a lot of potential here. Genes may influence the impact of insurance. That has many implications. Here we see a heterogeneous impact of insurance on smoking. Here are my comments, which I've already told you.
First of all, I liked a lot the paper. you sort of underselling. You call that heterogeneous small hazard. It's more than this. It's small hazard plus adverse selection, because definitely the insurance company doesn't know
Yeah.
the PG. And people, they might know, they might not know their PG, but they certainly know how costly it is for them to stop. So that's typical. And there are a few models in the literature that look at this adverse selection plus moral hazard kind of situation, in which people differ not only on the risk, but also on the cost of whichever measure will they can use to alleviate the risk. But that's the first time I know the theoretical literature is the first time that I see an empirical application that exactly fits this kind of model. So I think that's really very interesting. Now on exactly what the way your interpretation of the model. So essentially what I see here is you're taking people who have been insured all along, and that's 90 or 95% of the population. And then you look at the 5% who were not insured and are insured. And what you're telling us is those people, they behave differently, but that depends on their gene. The concern here is that those are very special people, right? It's the not being insured before the age of 65 is something special, and it's correlated with education, it's correlated with income, and so on and so forth. So it's not what you're saying. At the end of the day, you're concluding that it's the fact that they were not insured. This not insured quote qualification might be something that capture many other things, like background, education, and so on and so forth. So
Income type of job that they have.
exactly.
Yes.
So it all depends what kind of controls you're putting in your regressions.
I don't put any controls in the regression. I have an individual level fixed effect that tries to capture these type of long-term potential differences. So if you're the type of
You have individual fixed effect, but not on the interaction.
not
Not in interaction. So it might be that those people react differently, that less educated people react differently to shocks or something like this. Think in terms of cognition, for instance.
Yeah, no, I agree.
That's a possibility.
Definitely, and thank you for the comment before. So we do actually have a model in the appendix that has both adverse selection and moral hazard, but we don't have a way of disentangling the two well in the data. So for simplicity, we just go for the moral hazard because it seems to be the one that is the most. The change in behavior is usually mostly associated to moral hazard than adverse selection. But you're completely right that we were trying to look for another proxy for adverse selection, like another PGI for adverse selection, but we didn't quite find it.
Oh, okay. Now, my point is simply, if I was to design the optimal insurance contract in this model, it will not be a standard moral hazard model.
Yep.
The fact that there is adverse selection in addition means that the design of the deduct, because then you should offer a menu between the various deductible and so on and so forth. So the implication of this kind of finding is sort of deep, even for the design of insurance contracts.
Yeah. Thank you. Elbow.
So I'm trying to, so the timing would be like I'm 64, then I get a heart attack, and then I have a year to wait. So I like quit smoking. Okay. And then whatever happens after that. So I guess I kind of wonder what would happen if you looked at 63-year-olds or 62-year-olds. Because then I'm guessing, there's a much higher probability of not making it to 65 in the second heart attack. But then, of course, there's like the age problem that you control for that. And then, there's also kind of like the planfulness, right? I mean, there are variables that kind of ask how far people look into the future of the HRS. I'm guessing some of these folks who are uninsured don't think that long into the future. So these are just, these are kind of separate points, but I mean, I'm just trying to get my mind around the idea that you're saying that these are comparable groups, and one of them is saying, okay, it's worth it for me after all these years and a heart attack to quit smoking, but not for you, but just because these 8 months when I might get a heart attack. And I just want to, does that line up with the probability of a second heart attack at all? Because if it's like really small, then.
Yeah, so I don't do an RDD. Because there's too few people who get close to the.
Yeah, I don't need an argument. I'm just saying.
So I am.
Compare
I'm taking into account, I'm bundling together people who have a heart attack at 61, 62, or 63. They're all together.
I understand that. What I'm saying is that you should probably, I think you would find it big. I mean, if your reasoning is correct, I would expect, like, if I'm getting Medicare in a month, or
Yeah.
like tomorrow, it shouldn't affect my smoking at all. If I'm getting it in 4 years, I guess it should, according to some model.
Exactly.
That's
So
your model.
yeah. So, well, there are many.
Like,
I
you
guess
could,
the simple answer
could you
is
look
that
at like the
it doesn't
60-year-old and look at the
So
coefficient?
the simple answer is that I think it's more of a behavioral rather than a rational answer, in the sense that it doesn't seem that having a heart attack now is going to, and you keep smoking, is going to definitely increase your probability of having another one very soon. But that's what the doctor seems to be saying that to patients. They just say you have to stop smoking now, right away. And so
But you're still saying that they're thinking about the fact that they don't have insurance again and that they won't have insurance versus people who absolutely are insured. The doctors still also
Yeah.
think they don't smoke, and they're like, yeah, but I don't care.
I don't care because I'm gonna be covered.
Well, yeah, it'll be uncomfortable, but I'm covered.
Yeah.
So I'm just saying that, like, you want to look at the 60 and 61-year-olds versus the 64-year-olds and just see if there's a difference that's worth exploring, I guess, is what I would.
I'll look into it then.
John.
I find this results very plausible. What I find, looking at, I'm not an expert in this literature, but if you look at the work of Laurent and Benov and the Rand Health Insurance Experiment, the structural models, they all find a pronounced moral hazard on spending of being on Medicare. And then this interacts as if here's a behavior which they normally don't study, but it's a behavior that will increase your expenditures. And so you don't react as strongly when you know you're subsidized. So I find that very consistent with the moral hazard effect. The one thing though that Medicare doesn't insure is you die, right? So, they're not, maybe there's a death benefit to your spouse, but if you just don't if you like life, you should have a big incentive to stop smoking, even if you're on Medicare, right? So you might say there's a rationality to, you say, oh, I'm on Medicare, it's going to cover, another heart attack. I think that's really risky behavior, right? So maybe that's the behavioral aspect you're getting at, is that if you really care about your life, it doesn't matter what age you are, and the doctor says quit smoking, you ought to do that, right?
I mean, I think so. On average, we do see that everyone who suffers a heart attack reduces smoking on average.
Yeah.
There's this differential in the amount, the total amount of people who reduce smoking, and I think I'm using that type of variation. So I totally agree with you that the level of people who stop smoking is because they don't want to die, and Medicare is not going to help on that.
Yeah.
But there is a bit of variation
Yeah,
within
so you're
that I think
you're subtly picking that out, and that seems consistent with the moral hazard effect.
I mean, that's an interpretation of our results.
Seems very intuitive to me.
So
Do we have time? Yeah. I like this because it brings together the genetics and the insurance markets, and I think we should have more of that. I think it raises all sorts of very interesting questions. So one detail about the Medicare, I was curious of why the focus on the uninsured, because we know that a lot of the transitions from age 65 to, at age 65 is not only gaining insurance, but it's also changing the type, like generosity, right? Changing from, maybe private insurance, that's not that great, or adding Medicare as a second insurance, so that you have like a more generous package, adding Medigap, right? So a lot of seniors have just more generous insurance, which, so I'm kind of curious why. I mean, maybe you think the uninsured transition, the transition from uninsured to insured is I was just kind of interested on the rationale.
Yeah, so part of it is that that's what the literature has found. They do find that the people who respond the most are the uninsured. Those are the ones who are really that see a big difference in the coverage, and especially in terms of a heart attack. You go to the ER, usually the ER is covered by most health insurances. So maybe it changes the type of room that you have and how the quality of all the things, but ER costs are usually kind of covered with a quick pay, but they're covered. So a big difference is that smoking cessation courses are covered by Medicare, I think, but not by most. They're covered by Medicare and Obamacare, but not by most of the health insurance, private health insurances. And we tried to look into that, but we didn't find any evidence that people knew about it or picked it up, these type of things. So nothing on the side. But it's kind of data driven, the approach. Like the literature and the data seems to say the uninsured are the one who are responding.
We have time for like one more comment or question.
I just have a quick question about this, about the timing. Because you said the health shock it includes heart attacks.
Yeah.
Which also includes like diagnosis with heart disease, different types.
Yeah, so it's the first diagnosis of the first time that you've been diagnosed with angina or other type of heart problems. So it's a more broad definition of a health shock than
So it
just
could happen like you have heart attack. That's when you first.
yes, it could happen, but it could also just be you go to the doctor and so uninsured people don't usually go to the doctor, so don't have a lot of like most of the time they get diagnosed with other heart problems because they go to the ER because something bad happened to them. So, but
Yeah, I was just waiting, like, as an anecdote, my father-in-law recently got diagnosed with heart problems. A month later, he found out he had a huge blockage. A month after that, a few weeks after that, he had surgery. And then he was asking my wife a week later, so I don't have heart disease anymore, right? I can go back to they fixed it, right? So like, and so there's with some people, there's this very short time. So just sort of Swedish stuff. When you only know like if this happened within 2 years, like
yeah, we only have the 2 year. The HRS is asked every 2 years, and so we have in between. We just know whether in between the waves they were diagnosed with that. So I don't have more fine grained information on that.